Hello, welcome to another lecture from the series of lectures for thoracic, junior thoracic doctors. These are series of lectures for the junior doctors joining the thoracic surgery. So today we're going to talk about a very important topic, which is the enhanced recovery after lung surgery protocol, which is the ERAS, one of the very important topics and that have a direct impact on the patient's recovery. And as you will see, many of these items are easy to apply and things should be applied on all patients undergoing thoracic surgery. These items you can involve and apply in your daily practice. So when you see a patient in the clinic and during the wards and post-operatively, all these items can be even easily applied by junior doctors. So this is a very important topic. So the ERAS, or the enhanced recovery after thoracic surgery or after surgery, is not exclusive to thoracic surgery. It has been applied to thoracic surgery after being successful in other specialties. Actually, most of the papers that we will mention are imported from other specialties after achieving success. So the evidence-based perioperative standard practice proved to improve the patient's recovery. The ERAS protocol was first implemented in the colorectal surgery, and after the success, it has been widely applied over years. The first group was created in Sweden in 2010, and later the program was spread all over the world. There are, of course, because of the different surgical specialties, there will be some modifications. And in thoracic surgery, these groups, it involves a group of measures from the pre-admission to admission, intraoperatively and post-operatively, and all of them aims to improve the overall patient care and to minimize the complication and post-operative stay. The successful implementation of the enhanced recovery requires a multidisciplinary team approach and active patient participation. As you will see during discussion of the different items, it requires active patient involvement. You will also need the involvement of the lung cancer specialist nurses and physiotherapists, as well as respiratory physicians, nutritionists, dietitians. So it involves all the members of the team to improve the patient's outcomes. And the recommendation or the strength of the evidence for each item is different. Some of the elements will have a powerful or more impactful effect on the patients other than other ones. However, when they are applied in combination all together, they will have a synergistic effect. So all of these items should be applied as much as we can. So this is the whole paper. This is the paper on which the whole presentation is based on. So everything is just guided by this paper, which I really recommend you to read and go through. So we will just go through each item and discuss how we can apply this in daily practice. So as I mentioned before, in this paper, it mentioned in the beginning that the guidelines were developed through the meta-analysis of 38 studies in different surgical specialties, and they extracted or concluded several measures, which are start from pre-admission to post-operative, all through the patient's journey through the surgery. And these measures, when applied, will minimize the complications. And as I mentioned before, some of the items have more impact than others, but we should be able to to apply and implement them in combination, and this will have collectively a better patient's experience. These recommendations have been imported from other specialties, so they are tailored based on the needs and requirements for the patients undergoing thoracic surgery. So let's start with the preoperative phase, and this is when you will be able to see the patient in the clinic after has been referred from elsewhere, from the respiratory doctors or from other specialties. And this at this stage is very critical, because then you can make also a difference to the patient's journey. So in the preoperative phase, like pre-admission, patient should be routinely receiving dedicated preoperative counseling, preoperative nutrition. Patient should be screened for nutritional status or nutritional supplements. Patient should be counseled also about smoking cessation and alcohol cessation. Patient should be investigated, and anemia should be managed thoroughly. And also there is a room for rehabilitation, which is an important aspect of the preparing the patient for surgery. So pre-admission, when you see the patient in the clinic, it's very important to go through the procedure. And most importantly, to tell the patient, in addition to the complication and risk factors and the outcomes and what are we going to do, is what to expect after the procedure. This will help the patient to alleviate his fears and to be mentally prepared and physically prepared to the surgery. So after going through the procedure, you have to tell the patient that post-operatively you will be recovering, you will have some pain, and this is expected after surgery, and you will have multimodality management in terms of oral painkillers, of epidural analgesia or regional nerve blocks. You will have a drain coming out of your chest, which will cause you some pain and some soreness, but you will still need to work with a physiotherapist. You will need to do some exercises. You will be asked to leave the bed and mobilize early. This is going to be somehow hard, but you have to do this because this will improve your recovery. And then the patient will be highly motivated to follow to go through this journey, knowing what to expect. And this is very different from a patient who has been just told about the operation and going through it, and after the operation he's scared and he doesn't know what to do and he not expecting that. So this is very important aspect of the discussion with the patient. And at this point, it is very important to pick up patients who are having some some risk factors, because some of these risk factors can be modifiable. And if you modify or change these risk factors and motivate the patient to do them, to change them, this will result in impactful patient's recovery and facilitate the patient's early discharge. So one of the aspects that should be investigated and analyzed is the patient's nutritional status. So that's what we've seen before, counseling about surgical plan approaches, alternatives, expectations after surgery. So before going through the other items, there are several patient leaflets and also patient data which are available online, patient information and leaflets which can be distributed in the hospitals. These ones are of great importance for the patient because usually when the patient's surgery is delayed or there's time frame between the discussion and the actual operation, it's very useful for the patient to go through this information again. And also there are on the YouTube, if the patients try to sometimes Google the operation, will have be scared. But when you direct the patients to resources that are built specifically for the patient data, patient will be more informed and educated about what he has to do about the to improve his recovery and what to expect, and this will be more useful information. In many places, in several institutes and several hospitals, there are patients' leaflets which are directed to specific operations and also telling the patient what exercises they can do, if they need help for smoking cessation, what to expect after surgery, and all these useful data that the patient can utilize at home and read and go through them. As I mentioned before about the nutritional status, it's important to screen the patients to see who will need a more thorough and aggressive improvement of his nutritional status, and to give the oral nutritional supplements for patients who are malnourished. So patients who have a low BMI, like 18.5, or patient having weight loss of 10 to 15% in the past 6 months, or patient with hypoalbuminemia, these patients are at high risk of postoperative complications, so they need to be optimized preoperatively by giving nutritional support or to refer to the dietitian or nutritionist for more advice. Particularly that many patients undergoing lung cancer procedure are COPD. So this is characterized by high energy expenditure and weight loss. And in patients who are malnourished, there's worse and postoperative outcomes. So these patients should be optimized in the form of nutritional support and or nutritional supplements, and gaining even weight gain as little as 2 kg can improve the functional status. So another important and very critical area of counseling the patient preoperatively is smoking cessation. Patients who are undergoing lung cancer procedure or COPD, many of these population are smokers. So at this point, patients will be highly motivated to stop smoking, and it is very critical to not to miss this opportunity. So usually the patients have been trying before, like several nicotine replacement patches or vaping, or several techniques to help them to quit smoking. But when they have a diagnosis of lung cancer, and knowing that they are going through the operation, they will be motivated to stop smoking and becoming more having more efforts towards stopping it. So during the first appointment, check the patient's smoking status. And while the patients are waiting for more investigations or waiting for the surgery, it is a golden duration to stop smoking. So we have to counsel them about smoking cessation, offer him several techniques of prescribing nicotine replacement therapy or even drugs, offering him or referring him for more resources to help him to stop smoking, like group therapy. These patients will benefit a lot from stopping smoking, even at least 4 weeks before surgery. And patients who are usually will ask whether the stopping smoking at this time will be very late or would make a difference. And it is very important to tell them that when you stop smoking, you will make a very huge difference in terms of the complications. This will hasten the recovery and facilitate early discharge, decrease the risk of pneumonia and chest infection. And it's important to highlight these areas with the patients, so they will be highly motivated to stop smoking. Delaying the operation in the favor of stopping smoking is not recommended if the patient is for lung cancer operation. So it's also something to consider. The same goes also for heavy alcohol drinkers. They also should be assisted to stop drinking and consumption at least 4 weeks before surgery, and this will also decrease the postoperative morbidity. So there are, as I mentioned, there are many leaflets and things to help patients to stop smoking, so they can use or utilize these resources. There are also some books, and I believe that all the thoracic surgeons or every doctor in general should have some sort of training or reading about how to counsel patient and how to help patients stop smoking. And this will be a very valuable opportunity to make a difference in the patient's life. So another aspect of patient counseling and screening is to detect anemia. So patients with lung cancer operations, with lung cancer diagnosis, might usually have anemia, and this will also worsen the morbidity and mortality and increases the transfusion requirement and the systemic inflammatory response syndrome, increase the risk of complications. So this can be corrected with iron replacement therapy as a first line. If the patients are having severe anemia, they will have a fast recovery of their hemoglobin levels. Using blood transfusion preoperatively is not recommended because it's associated with poor outcomes. Another important topic is the pulmonary rehabilitation and prehabilitation. This is specifically is of high importance in patients undergoing lung volume reduction surgery and coiling or valves in the bronchial valves for management of severe emphysema. Usually these patients have very low or borderline lung functions, and they are high-risk patients. So optimizing the patients to the extreme is important to decrease or to minimize the high risk, which is already there. Patients who are usually having sedentary lifestyle or have not been exercising before, it's important even to counsel them to have this rehabilitation, to try to do some sort of exercises, refer them to the rehabilitation team. In counseling the patients who are already active, to keep themselves active till the day of the operation, going for walking. Patients can also go for aerobics as much as their condition allows. There's no like an ideal program or tools to assess the duration and success. However, it's generally patients should be encouraged to be fit and active and to do exercises till the time of the operation. During admission, previously, traditionally, their patients used to fast for a long time, like 6 hours before operation, and recently it has found that this increases the risk of insulin resistance and increases risk of complications. So patients can have clear fluids up to 2 hours before the operation and stopping the solids for 6 hours. Patients also with diabetics should not have a long fasting because this will increase the insulin resistance. So pre-anesthetically, also patients who have patients shouldn't be given routine anxiolytic medications because it shows that increased risk of delirium after surgery. Patients, as I mentioned before, when you counsel the patient and explain their procedures and risks and what to expect and who are the team he's going to see next, this will alleviate his fear and helps to release the anxiety. In patients with severe anxiety, melatonin can be used as an alternative. During preoperative phase, we're going to discuss the venous thromboprophylaxis and routine operative procedures, like in terms of prepping the patients and antibiotic prophylaxis and anesthetic management. So preoperatively, like a venous thromboembolic prophylaxis, patient undergoing a major lung resection should be treated with a mechanical VTE and pharmacological as well. Usually, patients should continue to have them the VTE prophylaxis, mechanical VTE prophylaxis, like the TEDs, till becoming fully mobile after the procedure. And there's no evidence to support the use of extended VTE after the patient has been mobilized and been discharged. The antibiotic prophylaxis, usually patients should have a single dose of prophylactic antibiotic prior to the skin incision within 60 minutes. And also patients can have chlorhexidine decontamination it has proven to decrease the risk of wound infection by 40%. The risk of infection in this thoracic surgery is not that common as other procedures, but it's going around 40%. And regarding to the intraoperative hypothermia, the thoracic procedure are associated with intraoperative risk of thermal loss because of the increased surface area of the pleura and increase the heat loss and the exposure from the pleural surfaces to the air. So patients should be pre-warmed, either with blankets, with mattresses, sometimes also infusion of the warm fluids. This because intraoperative hypothermia would increase the risk of bleeding and thromboembolic events and infection as well. So continuous temperature monitoring is important. For standard in anesthetic protocol, most of the procedure will require single lung ventilation to isolate what the lung on the side that the operation is working on. And this is using the W tubes. Usually they have a larger size, and there's a risk of having patients with sore throat after the operation. So some patients have a difficult airway and unsuitable for having a large W tubes can benefit from the bronchial blockers. With single lung or isolated lung ventilation, there are issue of increased risk of the injury to the ventilated lung, which is a normal lung, and also the risk of hypoxemia. So balancing that, previously was using of the high tidal volumes like 10 mils per kg. However, recently finding out that we can use a smaller tidal volume, like up to 6 mils per kg, giving a patient with the same oxygen requirements with a small beep to prevent the risk of hypoxemia. Sometimes also adding positive pressure to prevent the total collapse of the non-ventilated lung to decrease the risk of injury. There is also increased use or increased in some centers the use of non-intubated awake thoracic surgery. However, because this is still a procedure that's under the way and not widely applied, there's no sufficient evidence to support the use of this type of anesthetic protocol. Then we're going to talk about postoperative nausea and vomiting control, because it's a very common area, a common complaint of the patient after the surgery. So postoperative nausea and vomiting is a common postoperative complication in surgery in general, and also in thoracic patients. There are several risk factors that are implicated or increase the risk of the patients with postoperative nausea and vomiting. The female gender, the use of volatile anesthetic or opioid, patients with history of postoperative nausea and vomiting, prolonged procedure, and could using several multimodality measures will help to decrease the risk in patients who are at high risk of developing post-operative nausea and vomiting. So there are several risk factors, risk scoring models. One of them is APFL score. As you see, it gives 1 point for female gender, for patient with history of postoperative nausea, vomiting, or motion sickness, for smokers, for lung operations, and if the points is more than 2, They should be using two modalities of the multimodal analgesia of multimodal management of postoperative nausea vomiting, like two classes of drugs. And if it is more than two, then you have to apply for three or more. So the several medications for postoperative nausea vomiting, one of them is the ondansetron, dexamethasone. There's also anticholinergic drugs, and other drugs, other classes of drugs also can be used. With regard to the regional anesthesia and pain relief, the thoracic surgery is known to be a very painful procedure because this area is very richly innervated, and the incision itself causes trauma. The dissection through the muscle also add to the injury. The retraction, particularly if the patient's undergoing thoracotomy or open procedure, the retraction with the risk of injury or fracture to the ribs and compression of the nerves, as well as the drains, which cause continuous irritation of the pleura. All these factors increases the risk or increases the postoperative pain and causing the patient to complain of it after the surgery. It is very the postoperative pain, apart from other specialities in the thorax, is debilitating for the patient because the patient are taking his breath continuously, and because of the pain, he might cause a splinting effect. So the patient will subconsciously stopping his coughing reflex, minimizing his chest expansion, and this increases the risk of atelectasis and retention of secretions. So in order to overcome the problem, the preemptive analgesia is applied, which giving thoracic epidural analgesia before starting doing a skin incision. And it has appeared that it has a reduction. It has an impact on reduction of the acute pain after thoracotomy. And there's a question about whether it has an impact on the chronic postoperative post-thoracotomy pain. Other also intraoperative regional analgesia can be applied because with thoracic epidural analgesia, there is some risk of postoperative urinary retention and hypotension. So other regional blocks might be less coming with less side effects and as effective as thoracic epidural, like paravertebral catheters, which can be easily applied with a surgeon. By the surgeon with less time consuming and more effective in reducing the postoperative nausea, vomiting, and respiratory complication, obviating the risk of the urinary retention and hypotension. There's also the intercostal catheters, and also there's the serratus block, which is a novel technique, particularly useful in patients whom you can't get access to the ribs and getting from inside and applying the intercostal or paravertebral catheters, like patients undergoing pleurectomy, for example. So with postoperative multimodal analgesia, using this approach will help to minimize the side effects of opioids, which are associated with increased risk of postoperative nausea, vomiting, respiratory depression, constipation. So by using combination of nonsteroidal with acetaminophen, paracetamol, and opioid, this will decrease the side effects of opioids. For fluid management perioperatively, it was previously thought that very restrictive fluid regime will help to dry the lung and decrease the risk of alveolar edema. However, there's no data to support the use of the benefit of using a restrictive fluid regime. In contrast, it has impact of organ damage and associated AKI. So a balanced crystalloids over saline and allowing the patient to have fluid intake as soon as they are able to swallow and as soon as they are fully conscious is a reasonable regime to follow in thoracic surgery. Then we speak about the atrial fibrillation prevention and surgical techniques. So atrial fibrillation has a reported incidence of 12%. There are some risk factors like male gender, patient with history of valvular heart diseases or heart failure or previous atrial fibrillation or hypertension. However, there's no formal risk scoring system to use to estimate the risk of patients having AF postoperatively. It's also reported that patients who are having beta blockers and having them withdrawn abruptly have a high risk of developing AF. So for the American Association of Thoracic Surgery guidelines in 2014, recommended to avoid the abrupt withdrawal of beta blockers and to replace magnesium whenever patients have an AF, to administer Delciazem preoperatively and amiodarone postoperatively for patients with a higher risk. For surgical technique, it's in many centers, thoracotomy is still the standard approach for lung cancer procedure or lung resection. With thoracotomy, there's increased risk of postoperative pain and chronic pain syndrome because of the extensive tissue dissection and increased nerve damage, as well as the retraction and fractures of the ribs. So applying a muscle sparing technique might decrease the risk of tissue damage and might decrease risk of the pain. There's conflicting data whether this has an impact of the post-operative prolonged course of chronic pain syndrome. However, it is helpful to decrease patients to decrease the acute pain after surgery and should be applied whenever possible. Another technique to decrease the risk of postoperative pain in thoracotomy when it's needed to be applied is using intercostal nerve sparing technique. With intercostal nerve sparing technique, the intercostal bundle is dissected and applied to hang or over the inside the wound. This also helps the surgeons to use this flap whenever needed, like buttressing of the bronchial stump. Another technique that is helpful to reduce the risk, the postoperative pain by minimizing the injury of the inferior nerves and preventing the compression of the nerves during closure of the chest is the rib reapproximation by closing or making holes or drilling of the rib itself. And this will allow the risk, decrease the risk of compression of the nerve during the closure of the chest. Regarding the surgical technique itself, minimally invasive surgery or VATS procedure has been applied widely nowadays and is a standard procedure in most of the centers all over the world. And since then, it has been also more advances of the technique itself, from the 3-port to biport in some center and uniportal, which aims to decrease the risk of invasiveness of the procedure and decrease the risk of pain as well. So it is somehow, it's not available, it's not widely applied on all centers like uniportal, but it requires some learning curve. But whenever possible, minimally invasive or VATS procedure should be applied. We'll come then to an important part of your ward round routine and assessment of the patient postoperatively, which is chest drain management. As I mentioned before in the lecture of the chest drain management, you will find different types of the drains. So there's rocket drains, which is usually available in most of the places. And they are usually filled with water to a certain level to allow the underwater seal. Patients usually hang them on their hands while they're moving around. But when the suction is needed, patients will be instructed to, or most of the time will be attached to the place where it is applied or called suction. So the other types of drains that are available, but still very expensive and not widely available in all the centers, is the digital drains. So digital drains have found to be useful to apply the patient because patients can mobilize with them easily without the risk of being a spillage of the fluids inside them. If the suction is needed, which shouldn't be applied routinely in all patients because of the increased risk of lung injury and it is found to be unnecessarily in most of the patients, so it shouldn't be applied routinely. So with these drains, you are able also to assess and to document the amount of the air leak, and this will help for early removal of the drain when there is no air leak. So this should be applied, but however, as I mentioned, it's very expensive, so it's not much available in all the places. There's also the number or the amount of fluid drainage in which we will need to remove the drain. Sometimes the surgeons, it's most of the surgeon preference or surgeons own like a sort of thinking about what is the number of or what's the number of or what's the amount of fluid to remove the drains. So usually some of them would think about 200, 300. However, this research showed that if you remove the drains with an output of 450, that can be safely removed without the risk of recurrent symptomatic pleural effusion that requires intervention. So it is safer to remove the drain even at higher output, particularly if the patient has a paravertebral catheter that might cause an irritation and increase in the output of the drain, which is not necessarily a bleeding or a true fluid accumulating on the chest. There's also the number of the drains. The one drain is also is sufficient for the most of the thoracic procedure, rather than using 2 drains.
actually the routine application of two drains is very painful for the patient and it's not necessarily improving the patient's outcome. Then we come to the item of the urinary catheterization. So also traditionally, patients who undergoing lobectomy were traditionally catheterized because of the monitoring of the perioperative urine output and fluid balance. However, shouldn't be a routine procedure unless the patient is having a prolonged procedure like chest resection or pneumonectomy, or patients having thoracic epidural analgesia because this causes urinary retention. So it is reasonable to insert the drains in these people. However, a routine insertion of a drain of urinary catheterization is not recommended. The risk of postoperative urinary retention is not clearly documented, but some papers will say 50%. The risk factors are patients who are elderly males, patients with diabetes mellitus. However, there's no formal or there's no widely applied or validated risk scoring to detect these patients who are at risk. So, generally speaking, it is reasonable to insert the catheters in patients with thoracic epidural analgesia or prolonged operations. However, it shouldn't be routinely inserted for the purpose of monitoring of the fluid output. There's also conflicting data whether the catheters can be removed before the thoracic epidural analgesia is discontinued. Generally speaking, it's better to wait because there's still some risk of recatheterization in patients if the catheters is removed before the thoracic epidural is discontinued. Then we come to an item of utmost importance, which is mobilization. So there are many barriers for the patient undergoing thoracic surgery to early mobilize. One of them is the pain. So the patients will sit down having severe pain, even with all this multimodal analgesia, causing them to splinting and even minimizing their coughing reflex and chest inflation. Patient will be attached to many things like they having thoracic epidural analgesia or paravertebral catheter or urinary catheter, as well as the chest drain itself, which might be a rocket vessel with fluid itself inside it. So there are many parameters for the patients. They can be also attached to the patient-controlled analgesia and oxygen. So they are attached by several things, which hinder their early mobilization. Therefore, it is very important because prolonged immobility might expose the patient to the increased risk of the thromboembolic events, strokes, chest infections, pneumonia. So mobilization is very important, and we have to counsel patient before surgery of what to expect, and that he or she will be attached to all these things, but he will need to actively work with a physiotherapist and doing the chest exercises to reduce the postoperative risks of pneumonia and chest infection. The prophylactic use of mini tracheostomy is not, there's no enough evidence to support the routine use in most of the patients. However, it's reasonable to use them in patients who are expected to have a low cough reflex, frail patients, patients having retention of secretions, and just to stimulate the response of cough and to be removed as early as possible after the procedure when the patients are able to maintain their coughing reflex. Early mobilization is also important so that there's strong evidence to support that early mobilization has an impact on the patient's recovery. The use of non-invasive post-pressure ventilation is also recommended as a routine procedure in patients undergoing thoracic surgeries. So, in conclusion, these guidelines have proven effectiveness on the patient's post-operative outcomes in all other specialties, in several specialties. As I mentioned, that many of these guidelines have been imported from from papers originally implemented on other specialties like colorectal surgery, for example, but they have been tailored to meet the needs of a patient undergoing thoracic surgeries. You will find that there's several papers like meta-analysis, retrospective cohorts, and prospective cohorts assessing the some items of the previously discussed here. And there's increasing evidence that they also work for the thoracic surgery, so they are implemented. And also there are several ongoing clinical trials to assess to get the good quality evidence, because as I mentioned, the quality of the evidence is not homogeneous through all these recommendations. You will find that evidence is strong in some of the elements where there's paucity of evidence on other items. So there are several studies to assess or to provide good quality evidence to see whether these ones are really working in thoracic surgery. So for now, for all the thoracic surgeons, for all you young residents, we have to work as much as we can to apply most of the items as much as we can, particularly the ones with good quality and high evidence. However, we have to try to apply them in combination. Particularly, this is the part where you can make a difference in the patient life, particularly in the preoperatively, when you can counsel the patient in the clinic, where you can assess him for smoking cessation, post-operatively, encourage the patient's mobility, counseling the patient post-operatively about the importance of going ahead, alleviating his fear, and encouraging him to mobilize. That concludes my presentation, and if you have any queries, you can contact me. Thank you.